train station. Microphone check. 1, 2, 1, 2.
Finance Committee meeting. I'm informed of no citizens wishing to address the committee, so we will move straight to our minutes, and you should have your minutes. It's in your packet on your screen in front of you. There is one change to the minutes. Lonnie, I think Ms. DeBose missed her first meeting in JPS history, so she was not she was not there. But is there any other changes to the minutes that anybody needs to make? If not, we entertain a motion. Have a motion from Tim, a second from DT. Any questions or discussion? All in favor say aye.
Aye.
All opposed, same sign. That motion carries. Welcome, Reverend Emerson. Good to see you, sir. That will take us to our reports and updates. And first is Jill. Thanks for being here today, Jill. She's going to give us an update on the master facility plan project, the placemats, et cetera.
Good morning.
Ramon.
I have Ramon Gajardo here with me today. He's actually going to provide the update. As you recall, he works for Raymond and Company, actually is his company. And so he's been integral in our master facility plan over the last couple of months. So he's actually going to provide the update. I did also want to let the board know we did get a new program manager from Bratislavis, Cameron Geertsma. I don't know if I said his name correctly. He unfortunately had a death in the family, so he's not here today. But I look forward to introducing him to you guys next month. You'll find that he's a welcome addition. I'm very excited about him. We really enjoyed working with him, and I think you will as well. So with that, we'll let
Thanks, Ramon. Welcome.
Thank you all. And yes, I'm filling in for Cameron today. He will be presenting these in the future, so I do apologize for any errors that I may make in doing so. We're going to start off with the Psychiatric Emergency Center, PAC as we all refer to it as. Right now they're continuing to move forward. They are working on, drying in the building. As you know, the structure is up right now. They're going to be, where our main focuses right now are going to be on the city infrastructure work that comes into the building, the tying of that, getting the permanent power and things like that. So those are some of the things that we as a team are working high level with Bratislavis on, and the project is moving forward greatly right now. Go to the next one. Medical Home Southwest, that one is closed up right now. They are in the process of getting their permanent power. It is due to be installed any day, really. We are working on also coordinating already the medical equipment, the minor and major medical equipments. So you see that we've been starting those POs and things like that. So that project right now is progressing well and is still on schedule for a turnover in winter of this year. So yeah, or in winter.
Ramon
Yes,
or
sir.
Jill, and I'm not sure, we may need to defer this to John at Cumming, but when we look at the trajectory of cash flow projections and the cumulative on that particular project, the actual cumulative is a straight line across where it looks like it was projected to be a slightly higher trajectory. Is that a schedule issue, or is there some savings there we're not realizing, or do we even know?
You'll see that.
Okay.
Yeah, level back out next
Perfect.
month. Yeah,
Thank you.
absolutely.
It's probably a little bit of combination of that because there has been some savings captured, and then also sometimes billings do kind of level out there at the end and then come big all at once. So yes, sir.
Thank you.
We can move on to the next one. New parking garage. Again, they're in the ground right now, but they are coming out of the ground very quickly. And I'll tell you that because right now we're having our conversations about the precast concrete that will be coming in, that you'll start seeing the structure go up. The good thing is, again, it's not cast in place, so you're going to see that garage go up really, really fast. Now, don't think you can start parking on it yet because we still got to pour the decks, of course, for every floor. But nonetheless, it's going to come up really quick, and then you're going to think nothing's happening there for a while. But right, you're going to get really excited when it goes up there. You're like, wait a minute, we've looked at that for the next 4 months. But it's exciting. It's coming out of the ground well. We're doing really good on making sure that our safety is in place, making sure that we've got gates closed, things like that, so that we don't have our citizens wandering off into our project sites. But nonetheless, it's doing very well and progressing very well.
Perfect.
Any questions?
The only thing I'll add is next month, we will bring additional updates on all the projects. And so not only the placemats for the projects that are actually actively under construction, but where the other projects are as well from a design and programming perspective. So more to come next month too.
All right. Super.
All right. Thank you.
I guess the expectation is that Cameron will be given these reports moving
Yes.
forward.
He will.
Cameron will be introduced to everybody. He's our new Broadus Representative. A lot of great things are being said already, so thanks for that, and we'll look forward to meeting him next month. And Ramon, thank you for your work. I know we're going to have you with us for a bit longer.
Well, and the good thing is, I just want to add is, yes, with Cameron coming in, it is a welcome new face by all means. But really the collaboration right now that is now being established between the Broadus-Levis team and JPSN ourselves as well is really, really good and dynamic right now. And I've got nothing but positive thoughts right now about the future. And I know that together we're going to work through all of our challenges that we're going to incur, for sure.
Awesome. Welcome news. We appreciate hearing that. Ramon, thanks for being here today. All right, with that, we will move on to our CFO update. Rory, welcome, sir.
All right. Well, good morning. We have just a couple of items before we'll get into the financial report for the CFO update. We are working through budget, final preparation stages on that, and it will be finished for the August 8th reveal. And then the April through June Hilltop investment report has been posted to your board portal if you did not get an opportunity to see that. And then we do have the beginning of the audit work for our financial audit that has begun in the month of July. And then that really will pause for a moment and resume in October and then be completed by the end of the year. So that's going on with our external audit. So we'll jump into the financials here. As usual, you have your narrative. We don't spend a lot of time on the narrative, but we'll jump into the summary slide. In short, for the month, in summary, we had a very high admission month. We also had a very strong net income month due to a supplemental funding adjustment that I will discuss a little bit later in the report. And then days cash on hand is down 59 days over the prior year. That's a significant number. I'll also address that a little bit later. So expenses, we saw expenses be very in line with budget. And those, we saw kind of coming out of the year, kind of a slow start on expenses, but now we have really caught up to where those expenses are really in line with budget. So we'll go through in more detail, and if we need to circle back on any of these metrics, we can do that. But quickly on the statistics, urgent care continues to be a little bit below budget. We did make some changes in our out-of-network processes. Back in March, we began screening individuals that have a plan that we are not networked with, and that has trended urgent care visits down about 3 of the last 4 months. So those would have been visits we were typically not being paid on by the payer as we didn't participate with the patient's insurance. And then I mentioned admissions up 15%. That's 300 admissions in total. So June was a little bit stressful from a throughput standpoint on the organization. Dr. Davis is laughing at me, but
possibly an understatement.
Understatement.
So the team has maintained length of stay at below 5.37 for the last 3 months. Even with the additional throughput challenges, that's very, very good to be in that 5.37 range for length of stay. 3 months does make a trend, so the pressure is on now for them to maintain that length of stay. Let's talk a little bit about inpatient surgeries. Right on budget, just 2% above budget, and then we had the outpatient surgery decline last month that did correct itself, so we're within 2 cases of budget on outpatient surgery. Behavioral health and PEC kind of continue to trend down a little bit. We'll get over to the actual colored slide here, and you'll see that behavioral health clinic visit in the June numbers. In explaining that, it was really some resident PTO that kind of affected that clinic visit number. So we don't expect that to remain in future months. And then obviously PEC has been down, and we have talked about that extensively for the year. So any questions on these numbers?
Questions for Rory?
Okay.
Thank you, sir.
I do want to move to occupancy rate. We really don't talk about this a whole lot as we report out each month, but occupancy rate is defined as bed days of care. So how many days of care did we provide divided by the number of bed days available. So available for care is your denominator. So we were at 93%. Pretty unheard of when your occupancy rate is that high. And you can look back historically where we've been. So that gives you an indicator of how June was really moving a lot of patients through. So surgery, I would point out just a little bit on both inpatient and outpatient surgery statistics. Ortho is kind of leading the way, but we have had some general surgery numbers a little bit below budget. We've got some vacancies. We've had a couple of general surgeon vacancies that have been causing that in both inpatient and outpatient. But overall, as I said, we're still very much on track.
You see that changing with your HVAC work you're about to have to do for the surgery suites?
We are, we're going to see some impact, but we are budgeting really flat for surgical volumes next year when that starts to, when those HVAC units starts to go down. So it's there's a group already working on how we make that work. Our block time utilization, we're looking at moving procedures as needed to Jessica, the outpatient surgery location. So there's really just a vacancy issue here that's causing those numbers to be down. But we have a lot of block that kind of goes unused, but then we make up a lot of OR time after hours. And really, I was talking to Dr. Webb yesterday, and he was telling me about our day gets dictated a lot by what comes through the night before with trauma. So it does really alter our ability to be efficient because we have to take care of those urgent cases that come in during the night. So.
And I don't know whether Dr. Carla Putti, you may want to come forward, but I think the question that I ask often are we having patient surgeries delayed as a result of our surgeon being down in FTE surgeons? And we're not, you can see the orthodox like this because they can get their patients in much quicker. But Dr. Carla Putti, do you want to speak to this, especially as we start to bring down OR rooms? We are timing when we'll bring on those general surgeons. So
yeah. Thank you, Dr. Duncan. We've been doing a lot of work. We are going to try and explain this in phases. We are now doing a thorough review of what are the outpatient cases that can be safely done at Jessica. So that's one big book of work. We're trying to understand, in order to do that, what would be required? Would it be people, equipment, staff? Because it's not just taking procedures. We'll need to take infrastructure. So that's the work we're doing now. What we also did is we're trying to re-understand our data. So when we look at how we use our ORs, overall, we use them 96%. If you look at the hours, the total block time, 96%. But 44% of our cases are add-ons. That means they are not scheduled, they are not planned, because that's because of our front door. Sure. When you have 44% of your cases that are coming through your front door, it is you cannot have a 70%, 80% utilized block time, because if the block time is used very well, then there's no space for the add-ons. So what we're trying to do is how can we move cases from the main OR to Jessica, find additional time, and then bring those cases up. And so that's the book of work we're doing right now. We do have one vascular surgeon opening. I think that's seen a decrease in the vascular volumes, but that'll catch up once the vascular surgeon is here. But the OR is on our minds, all our minds. We're working, trying to figure out how to optimize it, especially with the closures that we are anticipating.
What is the FT situation when it comes to staff? How many staff down are we in surgery?
And physicians, I think the only one I've known is actually the vascular surgeon. That's been the biggest impact. The vascular surgeon, yeah.
And remind us, and Jill or Roy, you may have to help with this. When we finish the capital plan, our surgery capacity, specifically inpatient surgery capacity, will be what compared to what it is today? Roughly.
Whenever we start bringing down the ORs, is that your question? We have to take down 3 ORs at a time.
Well, once they're done, once they're done.
Facilities. Yeah, we're still working on the program, and we actually did a KPU study this morning, and we're finishing that up because, as you recall, we're doing a lot of outpatient procedures here on the main campus because we don't have an ambulatory surgery center on the main campus. And so it is we have a 2-page document actually that we went through today where we're staging inpatient, outpatient here, ambulatory surgery center, and then Jessica as well, and sorting through how many ORs we actually need at the end of the day. Because again, endo will be moving off main campus, right? The actual surgery on main will be split because we know we have outpatient cases that we're doing in the main OR just because that's where we have the facilities to do that. So ultimately, we're gaining ORs though. We'll gain ORs not only here on the main campus, we'll be able to take those appropriate outpatient cases to the ambulatory surgery center. So that'll be a net new. And then of course we have Jessica as well. So all in all, it'll be a gain in all 3 locations.
Our growth is in that outpatient surgery just because every year insurance is allowing more and more of what has traditionally been done in inpatient to move to outpatient. So I think it's a great strategy that the team is doing in really increasing that outpatient.
It's good for our patients as well. It's easy for them to come to an outpatient center. It's more efficient when you don't come to the hospital, of course. And so it will be the right place, for the patients.
So what does that do to the future of ambulatory service surgeries on this campus post-capital project plan?
We'll have the ambulatory surgery center. So really all outpatient procedures should be done in the ambulatory surgery center as appropriate, not in the main. And so the main will be truly inpatient coming through either the front door or scheduled inpatient surgery cases that, require a higher level of care potentially, or even an admission here after their surgery.
I want to stress the importance of what you just said, because 15 years ago, when we moved into the new campus, one of the first criticisms was we did not build enough bays for ER, and we didn't consider surgery well enough when we looked at volume. And so we've all had to kind of suffer for the last decade plus under what is a very stressed surgery schedule, and that delays patients' surgeries. And when 44% of them come in through the front door as opposed to being scheduled, it cinches it down even tighter. So one of the things I think we want you guys to do for us is keep us in the loop as programmatic changes take place on the capital plan so that we can see the impact on patients that are today having to wait 2 or 3 days for a surgery that hopefully as a result of all this won't. And it's been a long time, Ralph knows, and Dorothy too, it's been a long time concern at JPS, and we continue to struggle with it. And when you have 98% utilization, there's not a whole lot of room for error.
And that really goes for multiple areas. It's not just surgery. It's our inpatient capacity. It's our ED capacity. And so really these master facilities will bring not only where we need to be right now, but also contemplate space for the future as well. So even as we're looking at the OR space or we're looking at inpatient space, it's very important for us to understand what are we going to need when we open to take care of the patients that we need to take care of, but then also have space for the future too, and contemplate, all right, we may not need, and I'm making this number up, we may not need 25 operating rooms day one, but down there in the future we are. And so today we know we need 20, for example, and so we are going to cold shell 5 more ORs potentially for the future. So that's all part of this plan as well. And when working with our consultants, it's very important to understand not only today when we open, I should say, but then also what does the future growth look like for Tarrant County, county and for JPS, because what we don't want to do is build the facilities, to your point, and say, man, we're out of room already in all these important spaces, because then we start doing things in spaces that we don't necessarily want to do, and it's not best for the patient.
Yeah.
So you'll hear a lot as we're going through construction and designing about these flexible spaces, because we don't know what those spaces are going to need to be utilized for. But I think yesterday the term we heard was on-ramp, off-ramp, and so really, and it's a very iterative process that we're going through, even each year as we're going through the design of these new facilities, because healthcare is changing, and is changing in the right way in which people want care closer to home. And so you've got to have these flexible spaces within your brick and mortar to do it, so.
Well, we appreciate that. Dustin and I were talking before the meeting about the strategic plan and the sort of the evolution of the strategic plan. And one of the things we talked about is, as this moved forward, we have to make budgets on an annual basis, right? We don't get to make a budget that's 5 years that we adopt today. It's 1 year. But part of I think the point, and I appreciate Dustin bringing it up, is that we all need to stay in touch with the key performance indicators that do go beyond a 1-year trajectory, especially when it comes to volume and access. And those are the things I think in the strategic plan. I know we've contemplated that, but keeping those numbers up to date and be able to report those to us at budget time helps kind of get some of the answers for that. So we appreciate, and I know this is a bit redundant, but I appreciate the extra effort that's going into that. I know that's what's happening, but I think keeping the committee and the board in line with what we're doing when it comes to value engineering, weighing that against, future demand is an important policy issue, and I want to be sure it comes back to us so we understand it moving forward.
Trent, I want to say that I think that the ambulatory surgery area will be a big relief for those folks coming in on the trauma side. Mm-hmm. One of my goals is that patient schedules will not have to be bumped the way they are now. Yeah. Because having that ambulatory area, the trauma stuff coming in, we should have some capacity here, except you won't have that many surgeons. That's the only thing I worry about, is you're going to be doing more on the inpatient side by picking that up.
Yeah.
Ambulatory side, you're going to be doing the outpatient surgeries there. So that would be one of those areas that we need to monitor too. Because I do think when I worked here, the ER always bumped patient. ER health always bumped patient. So that is one of the goals of this ambulatory area, that will go way down or decrease.
Yeah, and that's a very inefficient way to do business, to have your emergencies with your scheduled cases. And so it's not good for patients, it's not good for patient satisfaction, it's not good for staff, and so for all those reasons.
Yeah.
Well, we've come a long way.
Yes.
In the last decade, and we still have a distance to go, but we appreciate the diligence you all are putting into understanding access and what that looks like moving forward, and how we balance that with budget and staffing needs. So thank you for your efforts on that. Sorry, I chased a rabbit, Rory.
That was a good rabbit to chase.
A couple of financial metrics. I did mention cash collections last month. We talked a little bit about these very high collection months, really a function of a couple of things. One would be additional CHIRP reimbursement for fiscal year 24, as well as just that volume that we talked about and the number of admissions. So that cash collection goal is the red line, continues to be right at or above that for the last 6 or so months. And then the connections membership, I don't know if we always notate it, but at the bottom you can see our new members outpaced our members rolling off of connections by about 2 to 1. So that's a good indicator that we're moving more of those patients, keeping more, retaining more, as well as adding more. So on the financial dashboard, this is the new dashboard that we look at from a threshold, target, and stretch. We are at 9 metrics, not including foundation, of course, at the bottom. But of those 9, 4 are at threshold, 3 are at stretch, and 1 of those is at target. And the only one not meeting some threshold, target, or stretch is that Connections membership, which we budgeted or set a target of 50,000. And so we're approaching that. I feel like by the end of the year, all of those will be meeting at some level of threshold, target, or stretch. So a good year from the standpoint of financial metrics. Over time, you can see is fallen. Medicare retention has grown from, I would say we started around 48%, and it's grown to 51. And then our left without being seen in the ED continues to be very low. And again, that length of stay has now finally hit stretch with those last 3 months of throughput and all the work that's being done there. So
That's a huge accomplishment, keeping that length of stay where you guys are keeping it with the volumes we're seeing. It's pretty amazing, actually.
A little bit on employee giving. Shannon's done a great job motivating employee giving. We're at 10%, and kind of the average across public hospitals is around 7%. So really talked about that a little bit yesterday at the foundation meeting, and really would commend that group of employees giving to the foundation and JPS. So we'll go to the income statement real quickly.
Can we back up? I had one question,
Yes.
just to understand the metric. Left the emergency department without being seen 3%, or actually, I mean, the year-to-date is 2.2%.
Right.
I'm assuming that's out of 100 people that showed up, 2.2 people left without being seen.
Correct.
For any number of reasons.
Correct.
Okay, thank you.
And that's a number they've worked really hard on, just with process, to be able to lower that number. I don't remember where we started.
Yeah, we were at 7 or 8%. The CMS standard.
We were a lot higher than that about a decade ago. Yeah, we were. Yeah.
Yeah, so 7 or 10% starting out. How long ago, focused efforts?
A little over a year ago.
About a year, so that's really,
I mean, thank goodness we don't track that for board members. I mean, that's just
left without being
attending the board
seen.
meeting
Yeah.
without attendance, yeah. We should put that on here.
We can get that on there.
Yeah, that's what I'm saying. Dorothy and I have been so good. Like, we get one. We get one. Come on.
Well, that metric has dropped through a whole lot of effort on the IES team, the
that's good.
staff team. One of the things, we completely redid our triage process, totally. And, so when people come into JPS now, they don't sit in a lobby for an hour and a half waiting to be triaged. It happens like that. And so fantastic protocols have been put in place to achieve that. And I don't care whether you're a public hospital, a charitable hospital, or a private hospital, you accomplish 2.2% left without being seen, you're doing a good job.
That's a good number.
Plus, we have a committee chair here that will go ballistic every year that goes up, so that has kept us.
I have personal stories. Amazing. Absolutely incredible. Yeah. It's incredible. Absolutely incredible.
Yeah, to have that number, wow.
All right, moving forward, that's a great question. Moving forward to the income statement, I really would point out this month, it is a very, very favorable month in net income of 31 million, but you will look and you will see at the very top section, supplemental Medicaid funding. So that is where the real abnormality is. We budgeted for DISH cuts. I want to spend just a minute here and talk about DISH, because we don't often even define what that is. DISH is an acronym for disproportionate share hospital. And what that means is our proportion of Medicaid and uninsured days of care to our total days are disproportionate. So therefore, we qualify for federal reimbursement to help make up that cost between caring for an insured individual versus an uninsured or a underinsured individual. So that's the definition of disproportionate. It's how they define it. And there's a threshold. If your days are higher for uninsured and underinsured to total, you qualify. And then you receive your pool of those federal funds and some state matching funds in DISH as well. But that was budgeted for in '24 to be about a $60 million cut. Those cuts were reversed, and now we have the final calculations. Not only did we get the amount that we expected to be cut, but we received a little bit more. And so that's why we're catching that up over the next 3 months. So it really will look a little bit different. It's not a budgeting error. It is a budget based on the cuts that were announced, and then they did not happen. So I want to go through that real quick. Any questions on DISH or DISH?
Budgeted for no cuts next year, right?
We are going to budget for no cuts. So we will not have this unless there are cuts.
Yep.
Correct. So other than that big highlight, everything is what I would call very consistent. I would point out that salaries year to date, when we are looking at a variance of such a small amount year to date, we've done a really good job managing the labor budget year to date. A lot of that has to do with that reduction in contract labor, but rarely, I would say, this far in the year we are this close to that labor budget. But we did have the one pension adjustment that I mentioned last month. We are going to see that a little variance for the next couple of months as well, that actuarial calculation that was done to kind of catch up on that pension.
Rory, I'd just like to add one thing. I mean, we were able, I agree, to be able to keep salaries within budget with the volume of work that we are actually doing across the hospital. That's usually when you start to see that trek up, is phenomenal work that the teams are doing.
Great job.
Inside of supplies, I would mention that really includes drugs and supplies. You don't see drugs called out on the income statement separately, but we do have a couple of things in supplies. Invasive labs, we were really restocking due to all the activity. We had to catch up a little bit on inventory, and then also just general supply chain adjustments for volume. We do have a little bit of extra supply costs there for the month, about $2.3 million. We continue to refresh our facilities. New carpet last month. I hope you noticed the nice chair this month.
It's awesome.
Yeah, so this is the room that Joint Commission arrives in, so we've got it looking.
Has nothing to do with you people on this board.
Sorry, you just lost
We'd put you in a barn if we could.
No, and then the only other thing of note on the financials, it's really, we are trending year to date about $5 million on levy adjustments. That's a little bit more than we would normally have. That's just what we're seeing with appeals and protests down at the appraisal district, as well as just that valuation change. We budget about $3 million there, so we're about $2 million over on the kind of ad valorem change.
And that deadline is passed now, so we should start to see the adjustments associated with those changes flatten out.
It does take a while for all that to kind of flow through.
I know Roger mentioned it several times. He was really concerned that this number was going to be a lot more than we thought in terms of the amount of protested ad valorem that we did not realize.
Right.
Doesn't appear that it's going to be a huge issue for us.
I wouldn't say exponential. Like I said, we budget $3 million annually, and it's just slightly over that. And there was a $1 million adjustment earlier in the year for a charter school issue. So,
Be good.
Okay, quickly on the balance sheet. The biggest thing I would point out on the balance sheet is you are now seeing a significant cash deficit to last year, but we did have to IGT for that DISH payment about $96 million in the month of June. So we will receive back from that intergovernmental transfer $190 million. So that's really why our cash has dropped a little bit for the month of June. And then we also did IGT, or intergovernmental transfer, for CHIRP in the month of June, which is $26 million. So CHIRP funds come through claims payments. So we put up the money up front, and then we get those throughout the year. So that's a little bit of the explanation on cash. That's not, certainly not a worry. It's just a timing thing that I wanted to point out with respect to cash on the balance sheet.
When and how do we realize the DISH reimbursement post-IGT transfer?
It'll be this month. Hopefully, it will be deposited to us in July. It could be, they're saying July 31st.
Okay.
It might swing to August 1st, but it's coming in the next few days here.
Okay.
So, yeah. And
Rory, question for you. So that money that's coming back to us, where is that shown on the balance sheet? Is that under the other current assets?
it would be a receivable.
Okay.
Yes, that's on the balance sheet. I'm looking at the other current asset number. It's large enough to be, included in that number.
Okay.
Once it's realized, though, it goes to cash, right?
Yeah,
Correct.
It goes to income.
I'm just looking at the year over year. I mean, you had $374 million.
Right.
And other current assets this year versus 159 last year. So I assume that's for the bulk of that, where that money's being capitalized.
Yes. We do keep adequate cash on hand to deal with those type of things, those large chunks, and so that is in an operating account that we keep. So we were prepared for that this year. We did not have to move money from investments or anything of that nature. So, and then some of the other things impacting cash a little bit. If you look at the just overall interest expense, we're running year to date somewhere around $14 million. Of course, that would be an additional expense to the organization we did not have on that bond issue. And then our expenses are up about $1 million a day over the prior year, just with inflationary items and salaries. So. Yeah, it's typically no more than a month. Yeah. Right. Okay, questions on financials?
Questions for Rory?
I would entertain a motion to approve the June 24 unaudited financials.
We have a motion from DT. Second from Reverend Emerson. Any question or discussion? All in favor say aye. Aye. All opposed, same sign. The motion carries. Thank you, Rory. That will take us to consideration of mutual amendment between Molina Healthcare of Texas and Tarrant County Hospital District, which is also your item, right?
Yes, sir. So a little background on this item. We are seeing a change in Medicaid procurement that begins in September, just 1 month away. So previously, Amerigroup, which is now WellPoint, shared the Medicaid Star Plus, which is changing, with Molina. So what's going to happen is Amerigroup will exit, and then Molina and United Healthcare will share that proportion of Medicaid patients. So we will see a migration from Amerigroup into Molina. So as part of shoring up that relationship, really, we did a negotiation with Molina. We were able to keep reimbursement stable with doing that, and we will start to see that shift to Molina and United Healthcare very soon. The Cook Children's impact that you've heard quite a bit about, that is next September. So we are not dealing with the Cook Children's health plan issue now. That would be next September that's effective.
Is that a big impact on us?
I will tell you that Cook's been a good partner, and that's the biggest thing that concerns me is that
They can sustain that.
we've had a good partner in them with resolving issues, and now they're going to exit, and we're going to have to deal with much larger insurance relationships. I mean, and that's what worries me. I don't know that it will be an overall reimbursement impact to us, but relationally, I think it's big.
Will it be a patient impact in terms of our pediatric capacity or any of the things that we're doing with our current patients?
The only thing that could change is if we happen to not have network status with one of the newer providers, which I don't anticipate with our volume being as high as it is. So it would take a motion to approve that Molina agreement.
We have a motion from Tim, second from Dr. Davis. Is that right? Did I hear that correctly, or was that Dustin? All right, Dr. Davis, any question or discussion? All in favor say aye. Aye. All opposed, same sign. That motion carries. Thank you, Rory. And now we'll move to approval of the hospital services agreement between WellMed Network. and
WellMed, yes. So
Hospital District.
a little bit of explanation on WellMed. WellMed started out several years ago as a primary care network predominantly, and then they have moved into specialty care with physicians, and they really utilized or piggybacked off the United Healthcare Network. And now this is really just a paper change where we are contacting directly with them through this WellMed agreement, and it will keep them outside of that United Healthcare agreement for contractual purposes. And so it's a positive thing. There's no rate changes at all. It's more of a relationship on paper change. So.
All right, need a motion on this one?
So move.
Motion from DT. Second from Reverend Emerson. Any questions or discussion? All in favor say aye.
Aye.
All opposed, same sign. That motion carries. It takes us to item C, consider approval of item D, approval of professional services agreement between Raymond Company and Tarrant County Hospital District. We heard from Ramon earlier. Appreciate him being here. So Jill, is this yours?
I'm requesting your approval for a professional service agreement with Raymond and Company through an RFP process. Raymond, led by Ramon Guajardo, was awarded the contract to provide ongoing owners representation services as well as advisory services for the master facility plan. That scope will include ensuring projects are completed on time, on budget, and within scope. So he will help provide, and his team will help provide overall leadership, governance, and controls, and be an owner's representative for JPS, essentially JPS's right hand in this project. This agreement has a one-year cost of $422,000 with a total cost of $2 million with an initial 3-year term with 2 one-year renewal options, and it does carry a 30-day out clause as well.
Jill, walk us through the process that was used to identify Ramon as the best option for this.
Well, we went through an RFP process, and we actually had 3 respondents that we went through our RFP committee. This company provided the best not only value, but also the services that we are looking to provide for us.
Yeah, so this is an important decision for us, and I know all of us have sort of suffered through the facility woes of this big of a capital project budget, and staff has worked very hard to make sure that we have continuity and we have information flowing that's accurate, and that we have the correct level of oversight when it comes to this huge project. Major staff changes, obviously, at JPS left us, in some cases, concerned that maybe we didn't have the level of oversight that we needed. Making certain that the broadest interface was adequate, given where JPS stood. So I think staff has done a great job of A, trying to identify the best firm for this service in light of cost, and B, follow up to make sure that we have improved representation and communication with Broadus, which they have now stepped up to do. And I think Ramona is going to be a huge help to us. But we don't take it lightly when we have to go out there and enter into another contract relative to the capital plan. But in this case, I think staff did a great job and went through a super process to make sure it was as efficient as it possibly could be.
Aren't they local also?
They're local, yes, just down the street.
So any questions on this item?
Is this replacing or enhancing what PwC was doing for us before?
PwC just as a component, they're a consultant to the Broadus contract, so they're one of our consultants. They provide a lot of the financial modeling for the projects. So this is different. This is really oversight of the complete program.
This is more akin to construction management oversight.
It's on the ground, yeah. And just having someone who can make those decisions in real time. Right now, it is a process in order to get it up to a position in order to make that decision. And so having someone with the skill set that understands where we're going and what those guidelines are, it allows for those decisions to be made closer to the work that's going on. And we'll need that, especially as we get into the towers. So.
Now, this is a one-year agreement with a 30-day out clause, so JPS has a lot of flexibility in this. We may not have to have this for 5 years, but it's structured in such a way as the board could allow this to continue up to 5 years, and we've got plenty of ways out if we need to take it. No. Right. Any other questions? Okay, then we need a motion to consider approval of this professional services contract with Framel. Reverend Emerson, second from DT. Any questions or discussion? All in favor say aye.
Aye.
All opposed, same sign. That motion carries. Thank you very much. Jill, Joy, we're going to look at the professional services agreement between Orkin and Tarrant County Hospital District. Those of you that are interested in pest control.
Pest control,
You're in the
that's right. I'm bringing forward for your consideration approval of this professional service agreement between the district and Orkin. This is included in our operational budget. We did go out for RFP, had multiple responses. This did present the best value and lowest cost, and is the incumbent, to the organization, has done a really good job from a pest perspective for us.
We've used them before, Joy?
Yes.
Okay. Any questions on this recommendation? Not, we need a motion. Reverend Emerson, thank you. Have a motion. Second from Dr. Fowler. Any question or discussion? All in favor say aye.
Aye.
Sign. That motion carries. Thank you very much, Joy. Now we will move to approval of additional spend for the services agreement between Language Line Services and Tarrant County Hospital District. Mr. Ridgway. How are you today?
Originally executed back in 2021. We utilized 2 vendors, and we actually severed ties with one of those vendors and are requesting to add additional spend to that contract based on continued utilization. This contract will expire in 2024, and we will go to RFP. 2025, and we will go to RFP for it at that time.
All right. Any questions for Ashley on this agreement?
I just had a couple.
Sure.
I assume this relates to personnel, that's why you're it, of course. I mean, any thought to bringing this in-house, or are we talking about languages that would be too difficult to keep somebody on staff for?
So we do have internal interpretation services, but we translate well over 100 languages, and so we need the VRR technology to supplement our actual internal staff.
Have you thought about learning them yourself, maybe?
We actually translate now, I believe, over 200 languages, 206, yeah, so the dialects, all of that.
Yeah.
And it does work alongside with Epic so that it can get set up for that visit and allow.
That's great.
Yes, so there's a balancing act there.
Yeah.
We asked DT if he would do it.
Yeah,
If you-
come on. Help us.
Sign language.
All right, you've heard Ashley's recommendation. Do we have a motion?
So move.
Motion, I didn't hear, I heard 2 at once. Tim?
Doesn't matter.
Motion, Reverend Emerson, second. Any question or discussion? All in favor say aye.
Aye.
All opposed, same sign. Thank you very much, Ashley.
Thank you.
Daphne, do we need to go into executive session? We don't have anything, okay. Well, then that should conclude our meeting. It is, yes, sir, Reverend Emerson.
I just want to comment on this is not but I just want to comment on the event that took place on Tuesday. Was really impressive. But one of the things I noticed, and Ashley said it at the podium, the length of service JPS has of employees. It's not like you got 1 or 2 years, but the employees who are staying long is really impressive. That says something for JPS.
Yeah, absolutely. Second, third generation.
Yeah.
Very, very impressive. All right, if nothing else, we will stand adjourned at 10:51 a.m. Thank you all for being here. I think some of us are going to stay for a follow-up meeting on the strategic plan, but otherwise, thank you. Go have a great day.